As we all know, cataract surgery today is a refractive procedure. Patients are looking for a solution not only for cataract but also for presbyopia. Spectacle independence is the target. With this target in mind, there are a variety of presbyopia correcting IOLs available. The first in this category are bifocal IOLs, which have two focal points. This provides good distance and near acuities but suboptimal intermediate acuity, and there's also the problem of diminished contrast sensitivity and dysphotopsia. Next are extended depth of focus IOLs, which have a single elongated focal point to enhance the depth of focus or the range of vision. This is done by a proprietary diffractive Echeleth design. There's lesser contrast loss and fewer photic phenomena. However, are these as effective for good near vision is a question. Thirdly are the trifocal IOLs, which have three focal points. This provides better intermediate acuity than bifocals, but because of the third focal point, what is the impact on distance and near acuities is a question. Also, is there worse contrast sensitivity and more unwanted photic phenomena with these IOLs? So to try and answer these questions, I'm going to be discussing three published articles today. The first article is Prospective Study of Bilateral Mix and Match Implantation of Diffractive Multifocal IOLs in Koreans, published by Yang et al. In BMC Ophthalmology 2018. Purpose of this study was to evaluate monocular and binocular visual outcomes for near, intermediate and far distance in patients implanted with diffractive multifocal IOLs with different add powers in the two eyes. It was a prospective contralateral study where two diffractive multifocal IOLs with different add powers were implanted in each patient. Technis 2.75 diopters in the dominant eye and Technis 3.25 diopters in the non-dominant eye. 20 patients were enrolled, but 19 completed the study. All underwent uneventful topical phacoemulsification. These were the outcome measures. Coming to results, when monocular visual acuities were analyzed at all distances, that is 5 meters, 80 centimeters, 60 centimeters, 50 centimeters and 43 centimeters, there was a significant difference at 1 month post-op compared to pre-op, and also at 3 months post-op compared to pre-op. In all these, except for the near acuity at 33 centimeters, in which there was no significant difference in the dominant eye, in which 2.75 diopters was implanted. But in the non-dominant eye, in which 3.25 diopters was implanted, there was a significant improvement in the near acuity at this distance as well. Similar results noted for binocular visual acuities at different distances. There was no significant improvement in the near acuity at 33 centimeters binocularly, but there was significant improvement at all other distances, distance as well as intermediate. Defocus curves were analyzed binocularly as well as monoocularly. So there was a significant improvement, there was a significant difference between the defocus curve of the non-dominant eye, which was better than that of the dominant eye, at defocus levels of minus 2.5, minus 3, minus 3.5, which corresponds to roughly intermediate and near vision. So the non-dominant eye, which was implanted with 3.25 diopters, had better visual acuity at all these levels of defocus. There was an increase in the mean reading speed and decrease in mean critical print size and threshold print size, and these differences were statistically significant. Patients were given a questionnaire to analyze their overall satisfaction, visual artifacts and spectacle use. So overall satisfaction, there was a significant improvement compared to pre-op at all distances. Visual artifacts, there were no significant differences between 1 month post-op and pre-op, as well as 3 months post-op and pre-op. And spectacle use had declined considerably at 1 month post-op as well as 3 months post-op, and these differences were statistically significant. Thus, due to mix and match implantation of bifocals, there was not only good distance and near acuity but also good intermediate acuity with increased depth of focus and better contrast sensitivity and fewer photic phenomena than shown with trifocals in previous studies. Strengths of the study wise, this was the first study on mix and match implantation of Technis bifocals, and limitations, there was no direct comparison with bilaterally implanted IOLs with the same add power. Article 2, Efficacy and Safety of Extended Depth of Focus IOLs in Cataract Surgery, a Systematic Review and Meta-Analysis, published by Liu et al. In BMC Ophthalmology 2019. Purpose of this study was to evaluate the safety and efficacy of EDOF IOLs by a meta-analysis. PubMed, Embase, Web of Science, etc. were searched. All clinical control studies between 2000 to Jan 2019 were eligible. Excluding duplicates and irrelevant studies, a total of 9 studies were included in the analysis published between 2016 and 2018. In all these studies, in the extended depth of focus IOL group, the Tecnis Symphony was implanted, and in the control group, it was either a monofocal IOL, Tecnis monofocal or Acrisof IQ, or the trifocal IOLs, Panoptix Fine Vision or AT-LISA Tri was implanted. Coming to results, in terms of uncorrected distance visual acuity, comparing the EDOF IOLs to the monofocal IOL control group, there was no significant difference. Comparing the EDOF IOLs to the trifocal IOL group, again there was no significant difference in the distance visual acuity. On comparing EDOF IOLs to monofocal IOLs, there was a significant difference in the intermediate visual acuity, and EDOF IOLs compared to trifocals, there was no significant difference in the intermediate visual acuity. Near visual acuity was significantly better in the EDOF IOL group as compared to the monofocal, as is also seen in the forest plot, where the diamond is to the left of the zero line, which favors the EDOF IOLs. And comparing EDOF to trifocal IOLs, there was a significant difference favoring the control IOL, that is the trifocal IOL. Binocular defocus curves showed significant differences between the EDOF IOLs and the monofocal IOLs at defocus points of -1 to -4, and between EDOF IOLs and trifocal IOLs at defocus points from -2 to -4. So EDOF IOLs were better than monofocals, but trifocals were better than EDOF IOLs. In terms of contrast sensitivity, comparing the Tecnis Symphony to the Tecnis monofocal, there was better contrast sensitivity in the monofocal group, and comparing Tecnis Symphony to the trifocal group, there was better contrast sensitivity in the EDOF or Tecnis Symphony group. Spectacle independence, there was significant difference between EDOF and monofocals favoring the former, and no significant difference between EDOF and trifocals. Thus, extended depth of focus versus monofocals, better intermediate and near vision with extended depth of focus, but the trade-off being more halos and decreased contrast. And between EDOF and trifocals, near vision not as good with EDOF IOLs, but better contrast sensitivity and lesser halos. Strengths of the study, it was the first meta-analysis of its type, and limitations, substantial heterogeneity, and also it only considered 3 randomized control trials, and the others were all non-randomized control studies. Article 3, Visual Performance with Bifocal and Trifocal Diffractive IOLs, a prospective 3-armed randomized multicenter clinical trial published by Kemak et al. In Journal of Refractive Surgery 2017. Purpose was to compare the visual quality and reading performance outcomes after implantation of bifocal diffractive refractive, trifocal diffractive refractive, or bifocal apodized diffractive IOLs. It was a randomized prospective 3-arm multicenter trial. 104 eyes of 52 patients were enrolled at 3 different ophthalmological centers. Patients were randomly allocated into 3 groups: the AT-LISA bifocal group, the AT-LISA trifocal group, and the restore group. The final number of patients who completed the study were 49, that is 98 eyes, 34 in the AT-LISA, 30 in the AT-LISA tri, and 34 in the restore group. On analyzing intermediate visual acuity at 70 centimeters, there were significant differences between 809M and 839MP, that is AT-LISA bifocal and AT-LISA trifocal, favoring the trifocal, noted at 3 months as well as at 12 months. Intermediate visual outcomes at 80 centimeters revealed a similar result. Intermediate visual outcomes at 90 centimeters also revealed a similar result, where the trifocal was better than the bifocal. Near visual outcomes at 40 centimeters, the only difference noted was between restore and the AT-LISA bifocal, where the restore was found to be better at 3 months, but this difference was not maintained at 6 and 12 months. In terms of distance visual acuities, all the groups did well and there were no significant differences. Binocular defocus curves were plotted at 3 and 12 months, where it was noted at 3 months that the AT-LISA group, AT-LISA trifocal group had a good visual acuity at defocus levels of -1.5, and the AT-LISA trifocal group again had a good visual acuity at defocus of -1.5, but at defocus of -2.5 it was the restore group which had the best visual acuity. Reading performance was comparable between the 3 groups with no significant differences. Thus, intermediate vision, there was overall better outcome with the trifocal group at 1 and 3 months, but this was not statistically significant at 6 and 12 months, possibly due to variability of outcomes at the end of the follow-up period with some isolated cases of PCO and temporal decentration. Defocus curves, the trifocals were significantly better than the bifocals for defocus lenses simulating intermediate vision. Strengths of the study: it was the first study to analyze the impact of the third focal point on visual acuity at 3 intermediate distances and at 12 months, and limitations: larger studies with more number of eyes needed to correctly evaluate outcomes. Thank you for your patient hearing. I would now like to invite Dr. Parul to conduct the panel discussion. The first question is for Dr. Somashila. I would like her to briefly comment on the articles.
Thank you. That was an excellent presentation.